Good evening, everyone. Good evening. My name is Alexandra, and welcome to another Excel Healthcare Institute NCLEX and Exit Review. It's truly a blessing and a pleasure to have you all here. Today, we're going to continue our journey through the nervous system, and this is also our first section in adult med surg. So we're going to go ahead and begin with a little review of what we did last class. We introduced ourselves and did a review of the anatomy of the nervous system. So when we're talking neuro, we first have to understand that the neurological system consists of the brain, the spinal cord, and the nerves. And also we learned last class that the central nervous system is made up of the brain and spinal cord, and the nerves are what make up the peripheral nervous system. So just a little closer look at the brain. The brain is separated, or the cerebrum is separated into the right hemisphere and the left hemisphere. The right hemisphere controls the left side of the body. The left hemisphere controls the right side of the body. You have three major parts to your brain. You have the cerebrum, the cerebellum, and the brainstem. You have different lobes to the cerebrum. You have 4 lobes: the frontal lobe, parietal, temporal, and occipital. We reviewed shortly last class that the frontal lobe is responsible for thinking, memory, behavior, and movement. Parietal lobe is language and touch. Temporal lobe is for hearing, learning, and feelings. Occipital lobe is for vision. The cerebellum, or sometimes they call it the little brain, is responsible for balance and coordination. Oh, one moment. And then the brainstem is responsible for breathing, heart rate, and temperature. So remember, we learned about a very important part of the brainstem, which is called the medulla oblongata. The medulla oblongata is what regulates your breathing and your heart rate. We also got into some specifics of the spinal cord. We talked about how the spinal cord is separated by region, by location. So the location of where that spinal cord corresponds with your body is given a landmark name. So you have your cervical or C-spine, thoracic. So this is where your chest is, and down to your abdomen. Thoracic would, it aligns with your chest cavity, okay? From the bottom of your neck down towards your abdomen. Then from the lower abdomen and farther down your back, you have the lumbar or L spine. And then you have your tailbone area by your buttocks, your sacral. And then you have the very bottom, the coccygeal. So you have your C spine, your T spine, your L spine, and your S spine. Remember, the higher up a cervical injury is, the more likely it is to be fatal. Because as we get higher up the neck, we get closer to the brainstem. The brainstem is where the spinal cord is connected. So basically, it's where the brainstem and the spinal cord connect. Okay, where the brainstem and the spinal cord connect. So the higher up a neck injury is, the more likely it is to damage the medulla oblongata, and therefore the person won't be able to breathe on their own. So that's why injuries at the C1, C2, C3 level are usually fatal, because they damage the breathing center and lead to respiratory failure. So that is very important for you to know. And remember, this is just a review of what we went through last week. We also learned about the meninges. So remember, you have 3 meningeal layers. You have the dura mater, arachnoid, and pia matter. So you have to know their order. So from outside to inside, or from superficial to deep, you have dura, arachnoid, and pia. Remember, the meninges are responsible for protecting the brain and spinal cord. Underneath the arachnoid is called the subarachnoid space. Okay, so anytime something is below a layer, we call it sub. So you have the dura matter. So everything below the dura is called subdural. Arachnoid, the layer immediately underneath it, is called the subarachnoid space. Okay. Then we learned about cerebrospinal fluid. Cerebrospinal fluid, it travels along the subarachnoid space, or within the subarachnoid space. And we learned that there's 125 to 150 milliliters of this cerebrospinal fluid, and it brings oxygen and it removes wastes. Cerebrospinal fluid also serves as a protective cushion because it will absorb the shock of some injuries to the brain. So when someone gets like hit in the head, the cerebrospinal fluid, it somewhat absorbs some of the shock and can help to possibly decrease the level of trauma from that injury. Make sure you know that a buildup of cerebrospinal fluid can lead to increased ICP. So then we learned about some diagnostic and imaging tests. So first up, we learned about X-rays. So the other name for an X-ray is called a radiographic image. So if someone's in the X-ray department, they might say, oh, if they're in the department where X-rays are done, they might say that they're in the radiography department or the radiography department. Okay. So, medical terminology will take you so far and it will help you on things, on the exit and the NCLEX. So, radio is talking about the use of radiation, and graphy is like to take a picture. So, it's using radiation to take a picture, and it's a two-dimensional picture to reveal. It looks at bones, okay, to look at fractures, dislocations, the size of bones, suture separation in the skull of infants, those little squiggly lines on the skull. When we get to pediatrics, we will learn that they have soft spots or fontanelles, so their bones are separated for a bit, anterior and posterior. And so that's so that as the baby's coming out of mommy's birth canal, the head kind of molds together. The bones can kind of fuse temporarily as the baby exits the birth canal. And then with time, obviously, those soft spots harden. But in the meantime, you can assess suture separation in infants before those fontanelles close by the time the baby's 18 months. You can also evaluate for bone erosion, maybe like osteoporosis and calcification, extra hardening of bones. Remember, pregnant patients should not get an X-ray unless it's absolutely, absolutely necessary, because we want to avoid exposing the unborn child to radiation. Radiation damages DNA, and it could cause the death of an unborn child. And also, radiation can lead to mutations in the DNA that can lead to cancer and other disorders. Next up, we learned about CT scan. And remember, if this is your first night, this is just a review, okay? We learned about CT scans. So whereas X-rays are going to show you bones, CT scans will help you to evaluate flesh. You can look for intracranial bleeding, lesions, cerebral edema. CT scan is one of the golden standards if you suspect your patient is having a stroke. You want them to go have a CT scan because it's going to tell you if the patient had a stroke or not, and it's going to help you to find out what type of stroke was it, okay? Is it hemorrhagic stroke? Is it an embolic stroke? This will help you to evaluate what type of stroke they had. Also, it can help you to determine if the patient has hydrocephalus, which is a buildup of cerebral spinal fluid. You would see that it would push the brain to one side. So whatever side the brain, like the excess fluid is going to cause a shift to the left or a shift to the right. You're going to see a pocket, a buildup of fluid. It can also show atrophy. Oh Lord, when you get on the floor, and your elderly patient has like a CT scan of the brain, usually it will say like age-related cerebral atrophy noted, and that's usually harmless, like because as we get older, our brain decreases in mass. Um, and also remember, CT scans can be done with or without contrast. Please, please, please remember that because it is your responsibility as a nurse to make sure that you have received the order correctly. So, last class we talked about before you get contrast dye, make sure you assess for allergies to shellfish, iodine, and radio opaque dye. If they are allergic to contrast dye, tell the doctor, and the doctor will probably order an antihistamine and a corticosteroid. The other important thing, not only do I want you to memorize, for CT contrast, make sure you understand, is it with or without contrast? If the healthcare provider was not clear in their order, you should call and get an order to help clarify. Also, there's the next slide I want to tell you. So we have a rule. Anytime your patient is going to be getting CT or contrast, excuse me, anytime your patient is going to get contrast, if they take metformin, you have to hold the metformin for at least 24 hours before and 48 hours after. So 24, 48, 24, 48. It can truly damage the kidneys and also lead to lactic acidosis if you do not follow this protocol. So one of a popular question on the NCLEX and exit could be the nurses reviewing the patient's at-home medications. 2 hours later, the healthcare provider orders for a CT with contrast to be done. Which of the following medications does the nurse need to discuss with the healthcare provider? Metformin. So that if the patient needs the CT scan immediately, you can call the healthcare provider and let them know that, hey, the patient was taking metformin at home so that the healthcare provider can make the decision. Do they want the patient to just get the CT without contrast, or can the CT with contrast wait so that the patient can be off the metformin for 24 hours? After getting contrast dye, so if there's, if you were in class last week, you already wrote this down, but if you're new, please write this down. Contrast is very hard on the kidneys. One of the best things you can do for your patient that has received contrast dye is encourage hydration. We want to help that contrast dye get out of the body so that it doesn't do any damage or overwork the kidneys. Okay, so if your patient got a CT with contrast, and let's say they're an elderly patient, there's no family around, they don't want to drink, you know what I'm saying? Maybe ask the healthcare provider, should we give him some IV fluids just to help get that contrast dye out, especially if he doesn't want to drink? Then we talked
Know
about an
how
MRI. MRIs are used to identify tissues, tumors, and vascular abnormalities. For MRI, so an MRI is a huge magnet. We learned about this last class. No metal object can enter the MRI. So please read the list. Pacemaker, implanted defibrillators, anyone who has a gunshot wound and the bullet has not exited the body, they cannot have an MRI. Pregnant women should not have an MRI because it can increase the temperature of the amniotic fluid and it could harm the fetus. Then we learned about lumbar puncture. So lumbar puncture is a procedure to obtain cerebrospinal fluid. We learned about the positioning and the site of lumbar puncture. Make sure you memorize that the site that they're going to access for the lumbar puncture is between L3 and L4. Okay. So remember we reviewed the areas of your spine, cervical spine, thoracic spine, lumbar spine, sacral spine, coccygeal spine. So remember that your spine, let me show you a picture. So this picture, you can't really see it clearly, but hold on, I just want to show you something really quick. Well, this picture you can, one moment. So your spine is protected by your vertebrae. So your vertebrae, like you can kind of see the lower portion here. So your spine, your spinal cord is encased within the vertebral canal. So you know what? I'm going to pull up another picture because I do want you to understand this very well. I think that knowing anatomy very well and medical terminology will give you a heads up. It will give you an advantage on taking the NCLEX and your exit exam. It's very important for you to be strong in both of those subjects because it can help you, along with using critical skills, to answer questions correctly. So give me just one moment. So these are your vertebrae or your vertebra, okay? Um, so as you can see, the spinal cord, you see the spinal cord connects to the brain through the brain stem, okay? So you have your cerebrum, your cerebellum, your brain stem, and your brain stem will eventually lead into the spinal cord. And just like we said, you have your C spine, your T spine, your L spine, your S spine. The names of the vertebrae or the vertebra, they correspond. So you have your cervical vertebrae, your thoracic vertebrae, your lumbar vertebrae, your sacral vertebrae. So here between L3 and L4, that's where they access with a needle to access the subarachnoid space to withdraw cerebrospinal fluid Okay. Another very important, well, another, interesting fact, should I say. And I know this picture's a little blurry, but it just shows you that depending on the location of the vertebrae, uh, they have a different appearance, so to speak. Okay. So your cervical vertebrae, they're a lot smaller, a lot more delicate looking. Then you've got your thoracic vertebrae. Here we have to start supporting, the back muscles. Okay, and then the lumbar get very big. So this is where your lower back is. There's a lot of weight and a lot of pressure. Okay, and they're separated by cartilage. Sometimes that cartilage can become damaged, like a slipped disc, herniated disc. Very painful. But we will talk about musculoskeletal conditions in module 7. We're in 4 right now. So back to neuro lumbar puncture, they're going to access the space between L3 and L4. Okay. The goal is to obtain cerebrospinal fluid. Either they're trying to measure how much there is, check the pressure of the cerebrospinal fluid, or also they just want to get it to test it. For example, if they believe that a patient has meningitis, they want to get a sample of cerebrospinal fluid to see, is it cloudy? Does it have high white blood cells? So for lumbar puncture, your patient has to pee before they do it. You don't want them having to get up in the middle of this. The position they're going to be placed in is called lateral recumbent. If you don't know what this means, please write it down. Recumbent, it refers to what part of the body is laying on the bed. Okay. So lateral recumbent, it means the side of the patient is laying on the bed. So you could even say right lateral recumbent because the patient is laying on their right side. So if she were dorsal recumbent, that means her back is on the mattress or the bed. So lumbar puncture, lateral recumbent with their knees flexed. If you can see, her knees are up. And then even sometimes they want you to be like a shrimp, where they want you to put your neck down and your knees up like a shrimp, to make like a C with your body, because it just makes it much easier for them to access the appropriate location. After a lumbar puncture, your patient must stay flat to avoid headache. Monitor their vitals, especially blood pressure. Here's an NCLEX tip for you. Please write this down. Anytime your patient has a procedure where they're removing fluid from the body, after the procedure, you have to watch their blood pressure, because blood pressure is dependent on fluid volume. So whenever we're losing fluid from the body in some manner, you need to watch their blood pressure. Also, if there's a risk for bleeding, which is, very common in procedures and surgery, watch their blood pressure. That will tell you if the fluid volume's too low and you need to replace it, or you need to find why they're bleeding. Also, monitor level of consciousness and monitor the dressing for leakage and CSF, leakage of cerebrospinal fluid. Cerebral angiography. So we didn't get to talk about this last class. Cerebral angiography. I want you to use medical terminology and tell me, what does this mean? So I'm going to unmute you guys. Tell me, what does cerebral mean in medical terminology? Hold on. Okay, everyone can unmute themselves. What does cerebral mean?
Brain.
Brain, beautiful. What does angio mean?
Inside, maybe.
Inside.
Oh, we got a future doctor. What does angio mean? Okay, have you ever heard the word angio before? Like maybe when we get to cardiac, we're going to talk about angioplasty, right? Angio means blood vessel, okay? And then what does ography mean? Like photography. What's going on when I take a photograph? What am I doing?
Pictures, taking pictures.
Beautiful. So anytime you see the word ography, I want you to take a picture. So guess what? I want you to write this down. Cerebral angiography. You're using contrast dye to take a picture of the blood vessels of the brain. You're using contrast dye, so just like this picture here, to take a picture of the blood vessels of the brain. So what are we assessing when they perform a cerebral angiography or when the healthcare provider performs a cerebral angiography? They might be looking for malformations in the blood vessels of the brain. They might be looking for potential blockages, okay? Cerebral angiography. So this picture helps you to see how they access the blood vessels of the brain. And this picture is going to be the beginning of a very important nursing milestone for you. You're going to see pictures like this for the rest of your nursing career. This picture is the beginning. We're going to reinforce this in cardiac because something similar is done for patients getting a cardiac cath. Instead, they wouldn't advance the catheter all the way up here through the carotids. They would keep it here through the arch of the aorta, and then they would access the heart in that way, to the left side of the heart. We're going to talk about this a lot in cardiac, so you really should be comfortable with it starting from now. Can someone tell me what artery did they access here?
Femoral.
Beautiful, beautiful, beautiful. If you do this tonight, you have what it takes to be a future ICU nurse. Tonight, when you take a shower, I want you to find your femoral. These things, I'm telling you, I used to do when I was in nursing school. One night I just found all my pulses on my body. Carotid, brachial, radial, femoral, the pedal pulse, posterior tibial. These are things I'm telling you, you do them. They help you to become a better nurse. Find your femoral artery. And one day you're going to use it to save a patient's life. And you'll remember that we talked about it. All right. Cerebral angiography. First thing is they have to access the blood vessels with the use of a catheter. This is what we call cardiac catheterization. Cardiac catheterization, we're going to learn about. So now this catheterization is inserting the catheter into a blood vessel. They're going to advance it up the abdominal aorta, and they're going to enter into your carotid arteries. Your carotid arteries are what feed the brain with oxygen. So once the catheter is in place, the brain surgeon or vascular surgeon is going to inject contrast dye. And then they're going to perform a diagnostic imaging technique called fluoroscopy. So I want you to write this down. So this is fluoroscopy. So this is a fluoroscopic image. It's like an X-ray, but a movie. Okay. So it's not like, colors or anything like that. So it looks just like an X-ray, but it's a movie that you can see in real time when the contrast dye is injected. And the contrast dye is going to highlight. That's what contrast dye does. It highlights structures so that the vascular surgeon can now see the blood vessels patent, or are there malformations like arteriovenous malformations of the cerebral blood vessels? Are there blockages? Is there a blockage of some type? Okay. So, putting it all into perspective, how did we even get here? We got here, we were able to obtain this image through the use of contrast. And before we were even able to give the contrast, we had to check the patient for allergies. Mr. Johnson, the neurologist and vascular surgeon have decided they need to do a cerebral angiography on you tomorrow. Are you allergic to shellfish, iodine, or radio-opaque dye? No, I'm not. Okay, perfect. Let me put that on the form. You made sure he has an allergy bracelet on and it doesn't say shellfish, radio, opaque dye, or iodine. Then you check his medication list to make sure that he's not on metformin. Because if he is, he has to be off of it for 24 hours before this procedure. And when this procedure is over, he has to be off of it for how long?
48 hours.
48 hours. 12 hours before this procedure, NPO. Some hospitals will say 6. You can ask your charge nurse for what protocol they follow. You can't go wrong with them being NPO after midnight. Now, we're going to talk about a very important nursing assessment technique that you will have to memorize to be successful on your exit exam and your NCLEX exam. It's called the 6 Ps. We're going to get right into it, but just one moment. So we just learned cerebral angiography. You're injecting contrast dye into an artery to visualize the arteries of the brain, the blood vessels of the brain. Pre-procedure, check for allergies. You want to hold any anticoagulants. That's another tip I can give you for your exit and your NCLEX. If it says, for which of the following medications should the nurse alert the healthcare provider? If you don't know what to pick and you see a blood thinner, pick it. So if you see warfarin, if you see aspirin, pick it. And we're going to learn about those in Module 5, Cardiac. The next module after this one. Remember your metformin rule. Post-procedure, I want you to memorize this. Vital signs. You accessed an artery with a catheter, and when the procedure's over, they're going to remove the catheter. They messed with an artery. You want to watch the blood pressure after. A patient could bleed to death in 4 minutes. So after this procedure, when they take this site out, when they take this catheter out, they call it when they pull the sheath. That's what they call it, when they pull the sheath. When they remove this, they're going to put a pressure dressing on it. Back in the day, they would call it a sandbag dressing. And guys, this is one of the major arteries. Look how big this artery is. Look how big this is. It's almost the size of this, but this one is the bigger one, the aorta. But look how big this is. They could bleed to death. Afterwards, you have to make sure that there's no bleeding or bruising here and that their blood pressure remains stable. Because if their blood pressure drops, that's the body's way of saying, hey, I don't know what's going on, but the fluid volume I need for a good blood pressure is dropping. Okay, I don't have enough fluid. My blood pressure is low, and you need to do something about it. Okay, so vital signs, level of consciousness, because we did just inject a chemical into the arteries of the brain. So if level of consciousness is affected, we need to notice that early on so that we can alert the vascular surgeon. Um, and that, decrease of level of consciousness, you did just mess around with the brain and a blood vessel, so that could also be a sign of blood loss. Keep the patient flat for at least 6 hours. They can't bend, bless you. They can't bend that leg. They cannot bend that leg because the dressing is going to come off and the patient can bleed in less than 4 minutes. Okay? Bless you. Bed rest with no bathroom privileges. What is that patient? So this is your patient right here on the left. If they get up to go to the bathroom, what are they going to do to that leg?
Bend it?
They're going to bend it. And then what's going to happen to the dressing? It's going to come
It'll
off.
come out.
And the blood is going to squirt out. And in 4 minutes or less, they could be a code blue. Okay. So they are on bed rest with no bathroom privileges. So they can use, if it's a man, a urinal, okay, but he is flat. You can hold his penis with his permission and put his penis in the urinal and let him pee. If it is a female or the man has to do a bowel movement, we can move them side to side and put a bedpan under them. Then you have to do your 6 P's. I'm going to give you some time to write this down. We're going to take a 15-minute break, and I want you to write this down, and I will be right back. Thank you so much. All right, so we left off on learning about the 6 P's. For your client who is receiving or who did receive a cerebral angiography, when they remove this catheter from the artery, so you're going to have to perform the 6 P's. Okay? So the 6 P's are pulse, pain, pallor, paresthesia, paralysis, and polar. So the first thing I want you to know is that you perform the 6 P's on an extremity. Okay? So you either do it like on a leg or an arm. And we're going to talk about like what are some reasons why you would have to do this. But so first thing is, if these are missing or inappropriate, even just one, you have to notify the healthcare provider immediately. Okay, so all of the 6 P's must be present and normal in the limb you are assessing. Okay. The other thing I want you to look at is neurovascular. That tells you what you're assessing. You're assessing the neurological function and the vascular status of an extremity. Okay, so write that down. The 6 P's, also called the neurovascular assessment, is how you assess the neurological function and vascular status of an extremity. Okay. So first you're going to, it doesn't matter which order you check it, but you check pulse. So if it's of an arm, you would check the radial pulse. If it's a leg, You would want to check the femoral pulse if you can, or the pedal pulse, okay? So like in this guy, you don't want to mess with the dressing, right? However, if you check the pedal pulse, where's the pedal pulse? I know that this body part's not showing in the picture, but where's the pedal pulse? Let me make sure everyone can unmute themselves. Everyone can unmute themselves. Where's the pedal pulse?
It's by the feet.
Yes, very good. So it's right on top of your foot. Okay. So I would also, for homework, I would like you to do that too. I would like for you to find your femoral pulse and your pedal pulse. So
Is that the one on your thighs?
the pedal pulse is the one on top of your foot.
But okay.
And so this is a very good learning experience. So let's say your patient just had a cerebral angiography or maybe even a cardiac cath, like another patient, maybe they had a cardiac cath. So you don't want to mess with this site. So why would checking the pedal pulse be effective?
Can you say that again, Professor?
So let's say, and let me look for a picture. Hold on, I want to put a picture of that.
So now you don't mess with dressing on the other side.
Hold on. I'm going to put a picture up and then I'm going to ask the question again.
Circulation.
Very good. Okay, keep going. What about it? Okay, so let's look at this picture together. So let's say here's the femoral, right? Let's say here's the femoral, and then the patient has the dressing over it. The dressing doesn't look like this. I'm doing it quickly, but they have the femstop dressing on, which we're going to look at a picture, right? Okay, so it's a little hard for you to feel the pulse. Okay, why would checking the pedal pulse over here? And if you feel the pulse, why as a nurse would you be like, oh, you know what? The patient's fine.
Circulation.
You want to make sure there is enough circulation to
Oh,
the area that is distal to the to the femoral.
very good, very good. Because excellent answer. You said the key word right there, right? So whenever there's an injury to an area, if there's a pulse distal to the area of injury, or in this case, the area that was accessed. So if there's a distal pulse, that means that the blood flow to this area is not compromised. You see what I'm saying? If blood can get all the way down here and you feel it pulsating all the way down here, that means that this area is definitely getting blood flow. So that's a very important concept that I want you to be comfortable with. Okay, so hang on. So now, patient does not have a pulse. You want to get a machine called a Doppler. It's very small and it's going to help you to detect a pulse. Okay. Now, if after that you still cannot find the Doppler, you want to go ahead and call the doctor immediately to avoid loss of that limb. Now, pain. When you assess the patient for pain level, let's say the patient just let's say the patient broke their arm or something, and the healthcare provider prescribed morphine. You gave them morphine, and 30 minutes later, they're yelling at the top of their lungs. They're in pain. They can't take it. Something's wrong. This is horrible. I mean, would you expect the pain level to still be so high after just getting the morphine?
No.
No, you would expect that with
Oh,
minutes, that the pain would have decreased. So when the pain is much higher than you would expect for either the procedure they underwent or for what they're dealing with, when it's like you just gave them pain medication and the pain is worse, you want to go ahead and let the doctor know and just make sure that they have a pulse and the other P's. But that's definitely something to take note of as a nurse. Next up is pallor. You want to look and see, is the limb pale? Because that means that there could be a lack of blood flow, okay? That could mean that the tissues are ischemic and they might eventually become hypoxic, cyanotic. Paresthesia, you want to ask the patient, do they feel numbness or tingling? Okay. Paralysis, if it's their arm we're dealing with, ask them to wiggle their fingers. If they can wiggle their fingers, there's no paralysis in that limb. If it's their legs, you would ask them to wiggle their toes, okay? If it's possible for them to move the extremity, ask them to do so. But like our patient who just had the cerebral angiography, because we don't want them to bend that leg for 6 hours, if they can wiggle their toes, then that is fine, okay? Polar or poikilothermia, feel you're going to palpate the limb with the underside of your hand, and you're going to assess if the limb is cold because we're warm-blooded. So wherever blood is missing is going to be cold. So these are the components of an appropriate neurovascular assessment. So we're going to go through each P, and I want you to tell me, is this neuro or is it vascular that you're assessing? Okay, so pulse. Is it neuro or vascular?
Vascular.
Beautiful. Pain.
No.
Neuro. Beautiful. Because the ability to sense pain requires your neurological system to be
System.
intact, right?
Right.
Okay. Pallor.
Vascular.
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 Beautiful. Beautiful. Because if there is not enough blood flow in the blood vessel and the limb becomes pale, that's a reflection of the vascular system. Paresthesia.
Vascular.
No pain.
Oh,
Not vascular. Paresthesia
It's
would be
pain.
neuro.
Neuro.
Yeah, paresthesia would be neuro.
No. No.
What about paralysis?
Vascular.
Vascular.
Mm-mm. Neuro.
Neuro.
So anything about sensation, that's neurological. Okay. So pain, numbness and tingling, not being able to move an extremity, we're going to put that as that's the responsibility of the nervous system. Okay. And for paralysis, also the muscular system, but without a functioning nervous system, you wouldn't feel pain that was a result of a muscle. Okay. So anyway, paralysis is neuro. Okay, what about polar?
Vascular.
Vascular.
Beautiful, beautiful, beautiful. Because you need the blood vessels open and working to get blood to the area so that it has the normal body temperature. Very good. Okay. So after the removal of the catheter, they usually place something on it called a femstop device. And you can see this is like a blood pressure cuff, like the squeezing thing, or called the pneumatic bubble. And it's going to be squeezed, and this is going to compress the site, almost what like a sandbag dressing would do, but much more effective and efficient. And this is going to prevent the site from opening up and bleeding. Okay. And so femostop, or some people call it femstop, the belt wraps around the patient for support. The pneumatic bubble is inflated over the arteriotomy. Okay, so medical terminology, we'll get back to that. Over the arteriotomy to compress the artery during and after sheath removal. Okay. Sheath removal. That's what we were talking about when they remove the catheter. Let's use medical terminology. Arteriotomy. What's arterial?
Blood vessel.
Blood vessel, but which one?
Artery.
Artery, very good.
Artery.
So if it says angio, that's blood vessel. If it says arterial, that's specifically an artery. And
Artery.
for vein, it could say veno, like VENO, or it can say phleb, PHLEB, like phlebotomy, right?
Mhm.
Oh, now let's see. So arterial is artery, and then what's otomy? Incision. So arteriotomy, the surgeon made an incision to access through the skin, correct? And through the artery, the surgeon has to make an incision in the artery to insert the catheter and access the artery. Okay. All right. Also, we did talk about this part in last class. So make sure you know that level of consciousness is the best indicator of neurological status. So if you want to know how the heart is doing, you could check the pulse and the blood pressure and do an EKG, right?
Mm-hmm.
If you want to know how the lungs are doing, you could listen to lung sounds, you could count respiratory rate, you can check oxygen saturation. If you want to check how the liver is doing, you can draw blood and check ALT, AST. If you want to see how the gallbladder is doing, you could check the bilirubin level, right? If you want to know how the pancreas is doing, you could check the amylase level. So all these organs, you want to know how the kidneys are doing, BUN, creatinine, right? All these organs, they have a way for you to assess them, some end value or end product that you can obtain to assess that organ. Well, it's not fair because what can you check for the brain, right? You can't like put a blood pressure cuff on the patient's head and check it that way, right? So it's like, how do you assess how the brain is doing? Well, you do that by assessing the patient's level of consciousness. How awake are they? Okay.
Mm-hmm.
The most accurate way to describe level of consciousness, because like, you could say, oh, he's awake, he's fine, he's sleepy, he's this, he's that. We want to stay away from words as the only way to describe level of consciousness, because when I was in nursing school, level of consciousness, we used words. We would say alert, lethargic, stuporous, obtunded, comatose. And so now what was stuporous to one nurse is obtunded to the other, is comatose to the other. So the words, there was just too much room for misunderstanding and miscommunication. Okay. So that's why we use numbers in the form of the Glasgow Coma Scale. The Glasgow Coma Scale goes from 3 to 15. And thank God right now we're all of 15. Thank you, God, right? Just make sure you know that a score of 8 and below is what we call coma. Okay. Last class we learned about there's 3 categories you're testing: eye-opening response, best verbal response, and motor. So that's in the last recording. We talked about it last class. So make sure you review it. Also, we touched base on ICP. So there's 2 numbers here you've got, or 2 ranges you've got to memorize, okay? So Glasgow Coma Scale is from 3 to 15. Normal intracranial pressure is from 7 to 15. If you want to pass the NCLEX, if you want to pass your exit, you have to memorize those ranges. Now we're going to learn, why would an increased ICP kill a patient? Okay, so we're going to go to the book. So you were supposed to read this for homework. Okay, and we're going to go to page 124. Give me just one moment to pull something up. Just one moment. I just want to pull a picture up.
Professor, we can't hear you if you're talking.
Okay, thank you. I'm here. I'm just pulling up a picture because I want to show you
Oh.
something. One moment, guys. All right. So if we're going to understand why increased ICP is a very serious condition, first we have to understand that the brain, it's kind of trapped. Your brain is just kind of trapped in your skull, and for good reason, right? Thank God. So there's many layers that anything would have to go through to even think about having a chance, a 1 in a million chance at getting to your brain, right? First of all, I know the picture doesn't show, but you've got your hair, you've got skin, then you have the periosteum, which covers the bone that covers your brain, which is called the cranium or your skull. Then you have three meningeal layers, the dura mater, the arachnoid matter, and the pia mater. And remember, the dura mater, medical terminology, dura, durable. Julab, durable is like very tough. So dura mater, it's Latin for tough mother. It's very tough. So the brain has so many things like surrounding it and protecting it. So that's very important to understand why when the brain gets swollen, there's nowhere for it to like swell out, you know? There's no room for it to go, right? So that's the first part I want you to understand. And then this picture kind of seals it in that there's really, like I told you, your brain is trapped. So it's like if there's a injury to the head and it causes the brain to swell, like your head can't go up here, right? Like your brain can't swell out this way. It's trapped. So whenever there's swelling and pressure, something's got to give. And we're going to learn about that. So the first thing that we have to understand when we're talking about increased ICP is there is some type of insult to the head. In the cases of trauma, you can have increased ICP from hydrocephalus as well, but I'm talking about when there's trauma. So let's say that there is some type of cranial insult, like this individual got hit in the head. As the brain swells and swells, and I'll use this picture actually, and let me just draw like a fake artery right quick. Okay, I know my drawing is horrible. Okay, these are just some ugly fake cerebral arteries, but you know what? Let me just do one more line. So this person has cerebral arteries, obviously, right? So they have cerebral arteries. Now, let's say that there's an insult to the head and this person gets hit really bad and it causes brain swelling. So what's going to happen is as the brain swells, it's going to compress against the skull. Okay, it's going to compress it, well, against the meninges too, and against the skull. And then the cerebral arteries get compressed because of the swelling. The cerebral arteries get compressed over a very hard structure. And then so now that area where the cerebral artery is compressed will not get oxygen. And because that area doesn't get oxygen, that area of brain tissue will die. And death of brain tissue causes more swelling. And that cycle will repeat itself until, I'm going to show you this picture. So now this next picture is a little dramatic. Okay. I don't know why it's not, okay. So this next picture is a little dramatic, okay. I don't think this could ever all happen at once. So these are different herniations, okay. So, but anyways, these are herniations. So when the pressure is unrelieved in the brain, eventually it will go somewhere. So now you can have a downward herniation and the portion where the medulla oblongata sits. I got to show you so many pictures. Well, okay, I'm going to show you. Okay, so now this person got hit, okay? And we see a pooling of blood. Do you see how the brain has shifted? We have a shift to the left that we would see on the CT scan. So when all else fails, the brain is going to herniate either through an opening in the skull, if the injury is that bad, or downward through the hole that connects your spinal cord to your brainstem, which is called the foramen magnum. Okay? And once that happens, immediate death occurs because the medulla oblongata will be compressed and the person can no longer breathe on their own. Does that make sense?
Yes.
Okay, and I know that it's a lot. So now let's go to the book so that we can kind of seal it in. So why increased ICP is a very dangerous occurrence. So first, there's some type of cranial insult, okay, like a trauma to the head. This naturally is going to cause edema. Anytime there's an injury, edema and swelling is normal. That is the body's response to injury, inflammation. So we're going to have tissue edema. So this naturally is going to already cause increased ICP. Remember, I showed you that picture. There's a lot going on, a lot of layers covering the brain. And in the picture, there's even cerebral spinal fluid swimming around. So all of this is going to lead to an increased intracranial pressure within the skull. Intracranial. Within the skull, the pressure will increase. This can lead to the compression of blood vessels, those cerebral arteries, as that part of the brain is swollen and pressed up against the skull. cerebral arteries get compressed. The area of compression will experience a decreased cerebral blood flow. The decreased oxygen to brain cells is going to lead to ischemia. Ischemia that is not reversed will lead to brain cell death. Okay? Around the area of necrosis or death, more swelling will occur. The ICP will increase more as the swelling increases more. This is going to lead to herniation of the brain out of the foramen magnum, and it's going to compress the medulla oblongata. Okay? Now, before it even gets to that, compression of the respiratory system, the medulla oblongata, compression of the respiratory system is going to lead to hypoventilation. Before we even get to herniation, compression of the medulla oblongata will lead to hypoventilation. What are you supposed to breathe out? When you exhale, what gas are you supposed to breathe out?
Carbon dioxide.
Beautiful, 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 beautiful. Carbon dioxide. Guess what? Write this down. CO2 is a vasodilator. You have to know that. CO2 is a vasodilator. So because the person's respiratory system is compressed, they're going to have hypoventilation. They're going to have a buildup of CO2 in their body. CO2 is a vasodilator. It's going to cause the blood vessels leading to the brain to open more. More blood will get to the brain. This will increase the ICP even more. Okay? And this can lead to brain herniation and death. So it's very, very important for you to understand why ICP is so serious. So ICP is on page 123 of the study guide, so please make sure you understand it well. Intracranial pressure is the pressure exerted by fluids such as cerebrospinal fluid inside the skull and on the brain tissue. At rest, a normal ICP is 7 to 15 millimeters of mercury for a supine adult. Some causes of increased intracranial pressure: trauma, hemorrhage, growths like tumors, hydrocephalus, edema, and inflammation. The major problem with increased ICP is that it impedes or reduces cerebral brain flow. Assessment of an individual with increased ICP: altered level of consciousness, headache, vomiting, pupil changes. Next up, I want you to memorize Cushing's triad. Guys, this is what we call true NCLEX and exit exam preparation. Without a doubt, you have to memorize this. So let me put up a picture for you. Okay, please take a picture of this picture. I want you to memorize this picture. So, and then I want you to write this sentence down. When a patient has increased intracranial pressure, their vital signs are the opposite of shock? When a patient has increased intracranial pressure, their vital signs are the opposite of shock. So when someone has shock, we know that their blood pressure is low, heart rate and respirations are high. But increased ICP is the exact opposite. And if you can memorize that, that can help you on questions. Now, there is a typographical error in the study guide, so let me show you. So where it says Cushing's triad, it should say high blood pressure, low respiratory rate, low heart rate, low respiratory rate. So if you have it printed, please make that correction. Okay. So now interventions when we're dealing with a patient who has an increased intracranial pressure. We want to monitor the respiratory rate. Remember, if the patient doesn't breathe enough, CO2 is going to build up, and CO2 is a vasodilator that will dilate the blood vessels of the brain and increase blood flow to the brain, which would make the intracranial pressure worse. So you want to monitor the respiratory rate to make sure that it's not below 12. And also because if they're hypoventilating, not only are they not getting out the CO2 the way that they should, they're not getting enough oxygen in. So we want to monitor the respiratory rate to prevent hypoxia and also to prevent hypercapnia, where they have too much CO2 in their body. We want to avoid morphine sulfate because that would decrease respiratory rate and make the ICP worse. Usually what they do is they put the patient in a medically induced coma. Now this is for like severe brain trauma. They might put the patient in a medically induced coma, and in a little bit I want you to tell me why. However, so when they put them in the medically induced coma, they might use a class of medication called barbiturates. Barbiturates like phenobarbital, okay? So these are going to heavily sedate the patient. Once we do that, the patient cannot breathe on their own. So we're going to intubate them and put them on a ventilator. And putting them on the mechanical ventilator, we can control their respiratory rate. And we're going to talk about that in just a little bit. Why do you think when a patient has increased intracranial pressure, severe traumatic brain injury, why do you think they put them in a coma? I don't get it. Why would they do that?
I think it's to
To,
control their breathing.
no, to raise the organs, to raise the
Okay,
brain, so
okay.
that it doesn't work so hard.
Very good. And you both are technically right. Yes, to control their breathing. Yes, because once we put them in a coma, we can put them on the ventilator, right? But you know, there's some downsides to being put on a ventilator, pneumonia and things like that. And also being put on the ventilator, it could be difficult to get them off of it, right? But yes, it's to allow the brain to rest. Beautiful. Now tell me why. What's the problem? What, can't we just tell the patient to go to sleep? Can't we just say, here, Mr. Johnson, get back in bed and go to sleep all day? No. Okay. So when the patient has a traumatic brain injury and it causes increased intracranial pressure, with them being awake, talking, watching TV, What does that do to their brain activity? Being awake, does that increase your brain activity or decrease it?
Increase.
It increases it, right? So
Yes.
think of it like this. Okay, you got two people. You got one person who sleeps in bed all day.
Mhm.
Then you've got one person who gets up and they run 3 miles a day, and then they exercise for 90 minutes. Who needs more food?
The person that is
The active person.
The active
The
person,
one that runs.
the one that runs, right? So the person who lays in bed, you're gonna be like, girl, you need to eat salad and drink water, okay? But the person who's running around all day and doing exercise, they need like pasta and some meat and and water, like something to really give them energy. So the more you do, the more energy you require, correct?
Right.
But we can apply that same principle to the brain. The more the brain is in use, the more energy it requires. So someone who's in a medically induced coma, their brain is at rest. The brain is the brain requires less energy. However, when the person is awake, the lights are on, the TV's on, people talking, they're doing stuff. Oh, gotta go to the bathroom. The more awake the person is, the more energy the brain is using. That means the more energy you got to put into it. Now, how does the brain get energy? Do we open up our head and throw a cheeseburger in it?
No.
No. So how does the brain get energy? It needs oxygen, right?
Oxygen. Yes.
Right. Through the blood. And how does it get oxygen?
Through the blood.
Through the blood, right? And what is blood mostly made of? 90% of your blood is what? Is water, right?
What?
Right.
Blood is liquid, correct?
Correct.
So the more the brain is in use, the more energy it needs to keep up with that activity, the more oxygen it needs. The more oxygen it needs, the more blood it needs. So if the brain is awake and active, it's going to bring more fluid, and that would increase the intracranial pressure. Does that make sense?
Yes.
So that's why it would be more ideal for the patient to be placed in a coma so the brain is at rest and it's using less energy and it doesn't need all that blood flow. You see? So that's why it's better that they're in the coma. So now, does that explain why in the neuro ICU, usually the lights are low in the patient's room? And it's usually very quiet. And in neuro ICU, you go to, the lights are on in the hallway, but I'm telling you, for the most part, the lights are very low in the patient room, and they usually keep it very quiet because bright lights and loud noises would stimulate brain activity, and that would make increased ICP worse. Okay. So that's why for the patient with increased ICP or at risk for it, we want to decrease environmental stimuli. We want to let the brain rest. Okay. Also, it would be very ideal if they're on the mechanical ventilator. I mean, which they would be if they put them in a medically induced coma. So we can monitor their respiratory rate and we could keep an eye on their PaCO2 level. Okay, we want to keep their PaCO2 level a little lower. So we're actually going to hyperventilate them a little bit. We want to avoid hypoventilation. So write that down. For increased ICP, we have to avoid hypoventilation because hypoventilation means too much CO2 and CO2 is a vasodilator. We want to avoid that. So we want slight hyperventilation where they're breathing out more CO2 than normal. Okay. Also, we want to avoid activities. You have to memorize those. Please, please, please. You have to avoid activities that would naturally increase ICP, straining, coughing, sneezing, bending, and Valsalva maneuver. It's like you act like you're pooping. Okay. For increased ICP, we want to keep the bed at 30 to 45 degrees. Why would we want to avoid Trendelenburg? What's Trendelenburg? Is Trendelenburg head down, feet up?
Yes, like lower
Yeah.
the head and the feet up. So you want to avoid shifting of fluid.
Very good. Because if we put them head down, feet up, all the blood's going to go to the brain, right?
Mm-hmm.
That would make
Right.
ICP worse, okay? Also, some other things that could increase ICP, flexing the neck, so bending the neck forward, that would increase ICP, and also bending the hips, because that would increase intra-abdominal pressure as well. Okay, so these are very delicate patients that require intensive nursing care. So that's why they're usually in intensive care unit. Okay. So some medications that will be used in the care of a patient with increased ICP, anti-seizure medications. Um, so just like in the scenario we described, where we said the person who lays down in bed all day, they require much less energy versus a person who's exercising. And imagine that same scenario, but someone would have like a seizure. A seizure would be like on the treadmill, running the fastest you could for 10 minutes. That's a lot of activity and it drains the body and it drains the brain. So we provide anti-seizure medications as needed and per protocol to help prevent seizures because seizures would severely increase ICP. Okay. They may be given prophylactically to prevent seizures. Antipyretics, fever increases metabolism. Heat increases metabolism. Heat, literally, the meaning of heat is the increase in the movement of molecules. Okay. And the caloric temperature. Now, heat increases the metabolic activity of the body, and that's going to increase like blood flow to the brain, and it would make the ICP higher. So usually, if we need to, we will use antipyretics to help prevent temperature elevation. Okay. Now, shivering, make sure you know shivering increases ICP. So usually they will give muscle relaxants, and we're going to talk about these medications over time. Okay. So the rest we're going to talk about, but there's one medication that stands out among the rest, and it is what we call an osmotic diuretic. So the major medication I want you to memorize for ICP is called Mannitol. Okay. So let me put it up on the screen for you. Hold on. Okay. So take a picture of this, or it's on page 132 of the study guide that you have. Okay. So Mannitol. Mannitol is an osmotic diuretic, and it helps to reduce the swelling and pressure inside the eye and around the brain, ICP. Um, so mannitol is used for brain swelling, helps to reduce the swelling of the brain. Okay. But keep in mind, it is a diuretic, so make sure you monitor their urine output. Okay. So the rest we're going to get into next class next week. We lost a week because of the hurricane and I had no power for 3 days, but we'll get back on track. So in the meantime, for homework, please review this recording so that you can be strong and increase ICP. And then go ahead and make sure that you have read the rest of the neuro chapter. If you did not already, please complete your neuro flashcards and your cranial nerve flashcards. Next week, we're going to get more into more diseases, more medications, and more symptoms. So you guys are doing amazing. And remember, one step at a time. Oh, and I have so much good news. One of our students, she passed. So
Wow.
yes, Miss Diana. She's gonna be telling us all about it. So just give her some time. She passed and then she went on vacation. Um, Yes. And she was only in the review for 2 months. So, yeah, so she passed. And you know what? Before she found my review, she took the NCLEX many times. And then she found my
Wow.
review and then she finally made it. So, and then she was texting me like, oh, she's so nervous. She doesn't think that there's one saying I say to people, and I don't know why. It's not because I say it, it's because Jesus is in that saying when I say it, and they usually pass the NCLEX. So before you go take the NCLEX, let me know so I can pray for you, and I'm gonna text you that saying. It's so funny. I realize that every time I text that to people. But anyway, so she was so nervous. I told her that, she's very smart. I do believe she's gonna make it, and she made it. So it's possible. I've been doing NCLEX review by the grace of God now for 5 years. And by the grace of God, I've helped a lot of people to pass and to get their license. And so you all will be next. If you're still in nursing school, I know that you're going to pass that exit and get out of there. And then it will be NCLEX review for you. So you will make it. You will make it. Never give up. And every day, even if you listen to 5 minutes of the recording, even if you do one question or 5 questions, every day, if you do it, and you know what I want you to do? You have to speak it into existence, even when it doesn't feel good. I will be an RN. I will pass my NCLEX. I will make it. And you will see. You will make it.
Amen.
Amen.
When God says yes, no one can tell you no.
Amen.
Yes.
Okay? So God bless you all. I will see you next week. And if you need anything, let me know. Thank
Yes, ma'am.
you, guys.
Thank you so much.
Thank you so much, Prof.
Thank you so much.
Thank you, Professor.
God bless.